carcinoma stomach. Yes.
Yes, sir.
Okay. So today I'm going to tell you about something about the uh, stomach cancer, the treatment of stomach cancer. Okay, last time we discussed about the different etiological factors. What is stomach cancer? What are the histological types? What is staging? And what are the different lymph nodal stations where we have to think about, and then how you are going to stage the disease, and then after, and the symptoms. And once you have seen all those things, and do an upper GI endoscopy and find out and take the biopsy, and then you can do an endoscopic ultrasound to see the involvement of the thickness of the wall, and then you can do a CCT abdomen, chest, and pelvis to look for the local disease and metastatic disease. So you stage the disease by doing a CT scan. So TNM staging, tumor, that is local tumor, N is lymph nodal stations, and M is metastatic disease. So how you are going to stage the disease by using CT scan, local staging of tumor and lymph nodes. You can do with ultrasound, endoscopic ultrasound, and and then there is very minimal role of FDZ PET. PET scan is not routinely used to know the metastatic status for stomach cancer. Okay, so this is what we have discussed. So endoscopic biopsy, then you know what type of adenocarcinoma, or maybe well differentiated or poorly differentiated adenocarcinoma of stomach, or it is something else. Sometimes could be lymphoma or GIST. Okay, GIST is nothing but gastrointestinal stromal tumors. So various types of histopathological diagnosis you'll get by doing an endoscopic biopsy. So once you get that, and then you stage the disease using various diagnostic modalities like contrast enhanced CT scan, CECT, and of abdomen, chest, and the pelvis, and then you can do an endoscopic ultrasound to know the involvement of the thickness of the wall of the stomach. Okay, so now after you do all these things, now you have to plan the patient for surgical treatment. So I will talk about the strategies of treatment. First, we'll discuss more of surgery, and then we'll discuss about the discuss more about the neoadjuvant chemotherapy, followed by surgery, and again followed by adjuvant chemoradiotherapy. So like that, we'll discuss about the treatment modalities. So we'll classify the stomach cancer into early and advanced. So we have already classified that. So if it is an early cancer, and then we discuss about the endoscopic treatment of the cancer. Okay, so endoscopic treatment of the stomach cancer, and then okay, then uh, so so let's start. Okay, so everybody is hearing to me, listening? Yes.
Yes,
Yes,
Mr.
sir.
Nest.
Okay. So now, spectrum. I'll just have a quick review of what has been done before. Okay. So spectrum of gastric cancer is the proposed progression will be chronic gastritis, chronic atrophic gastritis, then intestinal metaplasia and dysplasia, and then the adenocarcinoma. Okay, so symptoms I've already told you about: weight loss, abdominal pain, nausea, dysphagia, melena, and then early satiety and ulcer type pain. Okay, so signs, as we have already discussed about the palpable abdominal mass, and then the left supraclavicular lymph nodal involvement in metastatic disease, periumbilical node called Sister Mary Joseph nodule in the umbilicus of the stomach. Okay, so which the Sister Mary have diagnosed in Mayo Clinic. Okay, so she has seen patients with C carcinoma stomach with this type of nodules. Okay, and then left axillary node. Uh, and left axillary node, that is an iris node, and then Kuchenberg's tumor. So Kuchenberg's tumor, as you have already must have heard about Kuchenberg's tumor. So that is actually the pelvic deposit from the stomach. So transperitoneal or transcoelomic spread of stomach cancer into the pelvic, the ovaries, and then that is known as Kuchenberg's tumor, and then ascites. So these are the various signs of stomach cancer. We have already discussed about this. Then if you see this, there's esophagus, the cardiac end of the stomach, the lesser curvature. Can you see that lesser curvature is the length is very less as compared to the greater curvature. So whenever you get a tumor towards the lesser curvature, so it will involve the surrounding structure very early. Like I mean to say that it will involve the gastroesophageal junction from below, or it can involve the whole of the stomach. Like see, you can see the whole of the lesser curvature if it is involved. Then the treatment which you have to do will be a total gastrectomy. Okay, so you may have to do total gastrectomy if the tumor is located in lesser curvature rather than if it is located in the greater curvature posteriorly. Then you can get away with with a partial gastrectomy or a soft total gastrectomy. Okay, so that is how. And then see, if you see this picture, you can see the distal margin,
Excuse me,
of the
sir.
tumor.
Excuse me, sir.
Yes,
उसको slide ही change भइरहेछ न जस्तो छ सर
yes, it's
देखियो
all
कि
right.
छैन
I'm yes, it's all right. I know it. So now the thing
ए
is, if you want to get the tumor, the distal margin you have to take out. So distal margin has to be 2 centimeters. Okay. So whenever you do a gastrectomy, you should have a proximal margin of 5 centimeters and distal margin of 2 centimeters. Okay. So when you get a distal margin of 2 centimeters, then you can get tumor-free margin. And in the proximal side, you have to take, the 5 centimeter margin. So it's very difficult if the tumor is in the lesser curvature to get the proximal margin. So you have to go for a total gastrectomy. Okay. But if it is in the greater curvature, you can get easily the proximal 5 centimeter and the distal margin. Okay. So if you see this picture and if it is in your mind, then you can easily assume what could be the procedure, what you are going to contemplate the surgery, what type of surgery. And the aim of surgery is to get an R0 resection. So R0 resection, we want to get R0 resection means, see, if you see the stomach being folded up, behind is the pancreas. So sometimes if it is in the greater curvature, it may infiltrate the pancreatic capsule. So you have to remove the pancreatic capsule to get an R0 resection. So whatever surgery we do in malignancy, our aim is to get an R0 resection. That means the microscopic margin should be negative of tumor. That will be told by the histopathologist. The pathologist will tell you later that whether the tumor clearance, the margins are free of tumor or not. That means you have done a complete resection. Okay. Okay. So now, so gastric resection types, I'll tell you, just go through this in your textbook and find out what means by total, what is partial, distal, proximal, segmental, and in total, near total, subtotal, partial, distal, proximal. So there are various types of gastric resection done for benign and malignant diseases. Okay, so you should know about this. Just try to find out remember this slide and then find out what are the different types of resection. Go back and search. Okay. So now, so transaction of stomachs for various gastrectomies. I've already given you the picture here. You can see this is for the total gastrectomy. You have to go up to here, up to the lower end of the esophagus, So, and then you have to remove whole of the stomach. So that is total gastrectomy, which includes the greater omentum, the lesser omentum, the hepatoduodenal ligaments, okay, also will be cleared of fibrous fatty tissues, okay. So total gastrectomy, okay. So previously they used to do an splenectomy also, but nowadays we don't do splenectomy to get the tumor-free margin unless and until the spleen is infiltrated, okay. So now subtotal means here. So you should know the percentage, okay? How much is the subtotal, whether it is 75% of the stomach is removed, or and then the distal gastrectomy where about 35% of the stomach is removed. Okay, so just find it out. Okay, and then excuse me for a second. Hello, Azur. Now say, Azur. हाँ कसलाई फोन गर्नु okay okay are you here listening to me are you listening to me hello
Yes, sir.
okay so now the thing is okay so now the surgery for gastric cancer okay so I have told you about the different types and then the standard at least two-thirds of the stomach with a D2 lymph node dissection. So we'll talk about what is D2 means, okay that is standard. And then you just remember the palliative one where the urgent presentation with symptoms of bleeding or obstruction in the patient with unresectable or metastatic gastric cancer. Okay, so this is you just do an emergency surgery for the complication of gastric cancer. Okay, so the standard is D2 lymph node dissection with two-thirds of the stomach removed. Okay, so now, steps of gastrectomy. So first we mobilize the stomach and then we do a lymphadenectomy, that is D2 lymph nodes are removed. And then transaction, proximal and distal and reconstruction. So, so the thing is, the carcinoma stomach, the lymph nodal involvement probability is, for stage 1, it is only 5%. For stage 2, it is 25%. For stage 3, it is 90%. And for stage 4, it is more than 90. Very, very bad prognosis. So now, the stage 1, only 5% of the lymph node spread. So only 5% of the probability of lymphatic spread. So out of 100 surgeries you do, only 5 patients you get a lymph nodal spread. So the histopathological diagnosis, finally, when the pathologist will give you the report, they will say that the lymph node is positive in only 5%. So if it is stage 1. Okay, so the if you say about the lymphadenectomy, D0 means no neural tissue removed. If some surgeons say you, I have done D1 gastrectomy or D1 resection, then they will say that they have removed the perigastric nodes within 3 centimeters of the stomach. Suppose in an exam, somebody will say, ask you what is D1, then you say that I'll remove perigastric nodes within 3 centimeters from the surface of the lesser and the greater curvature of the stomach. And if it is D2, then that is the standard for now. D2 gastrectomy is the standard of treatment. standard of care. So removal of nodal tissue along the main branches of the celiac axis. So you must be knowing what are the branches of celiac axis, like left gastric, splenic, and then the common hepatic. So you remove the nodal tissue along these branches. So that is D2 plus the perigastric, that is D1. So D1 includes, D2 includes D1 plus removal of the nodes along the main branches of the celiac axis. So in D2, you remove the perigastric nodes as well as along the main branches of the celiac axis. So that is D2, okay? So just remember D2 and just know that there is something known as D3, okay? So, but don't remember D3 and forget D2, okay? So D2 is the standard of care, okay? Okay. So you see the lymph nodal stations, okay? You can see the numbering. You can see the number one at the gastroesophageal junction along the lesser curvature, number two at the gastroesophageal junction along the greater curvature. We call it right paracardiac and left paracardiac nodes, okay? And then three along the lesser curvature and the four along the greater curvature, okay? So then five is the suprapyloric and six is the infrapyloric, and then along the pylorus, okay, along the antrum, and then the seven will be the left gastric, and then the eight will be the common hepatic, and then nine will be the celiac axis, and then 10 will be the hilum of the spleen, and the 11 will be the proximal splenic, and the 12 will be the hepatoduodenal, and the 13 will the inferior pancreatic, 14 will along the supramesenteric vein, and then the 15, 16. Okay, so 15 will be in the middle colic artery or the vessels, and then 16 will be the para. So there are various stations described. And then 17, 18, we just don't remember those things. Just remember for stomach cancer, it is the 16 stations. So if you remove from 1 to 6, it will be D1. Okay. So, and then if you remove 7, 8, 9, 10, 11 and 12, then it will be D2. But in 12 also you can see the sub classification, and in 11 also you can see the sub classification, and in the 8 also you can see the sub classification. So in these cases, according to the location of the tumor, you remove these nodes. Okay, so you need not remove all 8, all 11, all 12, and all 10. Okay, so the thing is, you can see that I have different stations. I have written it in a page where the right, left, lesser curvature, short gastric, that is the 4, left gastroepiploic 4SB, right gastroepiploic 4D, okay, and then suprapyloric 5, infrapyloric 6, 7 is left gastric artery, 8A is anterior common hepatic, 8P is posterior common hepatic, 9 is celiac artery, 10 is splenic hilum, 11P is proximal splenic, 11D is distal splenic, 12A is left hepatoduodenal, 12B is posterior hepatoduodenal, 13 is retropancreatic, 14 V and A is artery and vein, 15 is middle colic vessels, 16 is aortic. Okay, so like this it is classified, but you should know 1 to 6 removed means D1 resection, 7, 8A or 8P, then 9, then 10, and then 11P and 11D. So all these will involve D2 resection, which is the standard. So see now, D1, see D2, you can see D1 plus 8A, 9, 10, 11P, 11D, 12A for total gastrectomy. See, But for distal gastrectomy, you can compare D1 plus only 8A. There is no 11G and 12A. So that's all for distal gastrectomy. Okay, if you remove the antrum. Okay, so about 35% you remove. In that, only these stations are removed. But if you remove the total stomach, then more you have to remove. So that is 10 you have to remove, and then 11G you have to remove. Okay, in addition to the mentioned one. Okay, so this is the same representation. And then reconstruction following gastrectomy. Okay, so if you do a Billroth 1, then you do a gastroduodenal anastomosis. So Billroth 1 is nothing but, it is just removing the antrum of the very small amount of stomach is removed. So that is the antrum of the stomach, and then you can mobilize the duodenum, and then you can mobilize the stomach and do a direct anastomosis with the duodenum. So that is Billroth 1. Usually it is Billroth 1 is the type of anastomosis. It is not the type of surgery. Okay, so many times the students, they mistaken it for the type of surgery. If you say I'll do a Billroth 1 surgery for carcinoma stomach, that is wrong. Okay, you will say that I'll do a distal gastrectomy and do a that is distal gastrectomy. You mean to say that I'll do a D2 gastrectomy. So D2 distal gastrectomy with Billroth 1 reconstruction. So reconstructing the removed part of the stomach by making an anastomosis is the type of Billroth. Okay, so you do a Billroth surgery for benign tumors also. So if there is a benign ulcer in the antrum of the stomach, which is not being treated by medical treatment, so that is the gastric ulcer which is not being to large gastric ulcer more than 3 centimeters, or which is not treated by the medical treatment. In that case, you may have to resect that part of the stomach and do an Billroth 1 reconstruction. So that is also applicable for benign disease. But if you talk about malignant disease, then you will say that I'll do a D2 distal gastrectomy with Billroth 1 reconstruction. Or you'll say that I'll do a subtotal gastrectomy, D2 gastrectomy, subtotal D2 gastrectomy with Billroth 2 gastrojejunostomy. So now see, there is a difference. Billroth 2 is you will not be able to pull the duodenum and stomach and make an anastomosis. Billroth 2 means what you'll do is you'll make an anastomosis with the jejunum, okay, jejunal anastomosis. So you will pull the jejunum up and connect with the stomach. So that is Billroth 2 gastrojejunostomy. So you'll do a D2 subtotal D2 gastrectomy with Billroth 2 gastrojejunostomy, or you'll say I'll do a D2 subtotal gastrectomy or Roux-en-Y gastrojejunostomy. Okay, do you understand that? Okay, so if you remember this much, that is well and good. So I'll show you some photographs of gastrectomy being done. So you can see we have positioned the patient, done a painting, and then done a draping. You can see the betadine solution in around the umbilicus. And then you have opened the abdomen. You can see a retractor there, which is retracting the right upper quadrant of the abdominal muscles and fat and the skin. And then you can see the liver and then the falciform ligament. And you can see the stomach there with greater omentum and superiorly the lesser omentum. Okay? And see, we have started the dissection by removing the greater omental attachment to the transverse colon. You can see we are using the cautery, electrocautery. Okay, so we are using the electrocautery to make the holes in the omentum. So see how the greater omentum gets adherent to the transverse colon okay, and then it reflects back and gets adherent again back to the stomach. So you can see the two layers. If you see that hole made by the cautery, you can see the two layers of greater omentum. Two lines are there. Okay, so the greater omentum being detached from the transverse colon. So now anterior layer of the transverse mesocolon. So when you start dissecting the greater omentum, then you lift it, then you reach the transverse mesocolon and you remove only the anterior layer. If you remove anterior posterior, then you have to remove all the vessels. So you preserve the vessels, removing the anterior layer of the transverse mesocolon. So now, once you have removed the transverse mesocolon anterior layer, you can see that I have put the marking there. Then we go up to the anterior capsule of the pancreas. See, we reflect all those flimsy layers and remove the anterior capsule of the pancreas. Okay, so this is how, yes. देखिया छैन? You are not seeing the pictures? Impossible. Some
सर
problem with your
देखेको छ
network.
तर स्लाइड 10 मै छ
केमा छ?
स्लाइड चेन्जै भएको छ
अहिले देख्यो? चेन्ज भयो?
यस
ए मान्छेहरु यत्रो बेर बोलिसकेँ मैले. See the position. I'll do like this. Okay, position of the patient. Okay, can you see that?
यस सर
Okay, can you see the liver? Just tell me,
Yes,
are you seeing it?
यस सर
Can you see now?
यस सर
Okay, you can see the stomach, the liver,
यस सर
and then you can see I am dissecting the mesocolon, the greater omentum from the transverse colon. Yes.
यस सर
Okay, and then anterior layer of the transverse mesocolon. Yes.
सर फेरि चेन्जै भएको छैन
अब मेरोमा चेन्ज भइरहेछ, तिमीहरूको नेटवर्क स्लो भएको हो कि? अरूले सबैले नदेखेको हो कि एकजनाले मात्र नदेखेको हो?
सर देखिरहेको थिएन सर.
कसैले देखेको छैन?
थिएन सर.
ए अहिले देखेछौ? ए okay, I'll show it like this only. Okay, no problem. Okay, so can you see the transverse anterior layer of the transverse mesocolon?
Yes.
Are you seeing that?
Yes, sir.
Just tell me yes. Okay. Okay, then can you see the anterior capsule of the pancreas now? So the dissection have reached up to the anterior capsule of the pancreas. See, the transverse mesocolon is there. We have removed the omentum which is attached to the transverse colon, and then remove the anterior layer of the transverse mesocolon, and then you can see we have reached up to the anterior capsule of the pancreas. Can you see that?
Yes, sir.
Yeah. Okay. So, okay, good. And then see now, you can see the vessels, the anterior layer of the capsule of the pancreas. We have removed that area, and then you can see the naked vessels. See this? Common hepatic artery, the celiac axis, the splenic artery, all the branches of the celiac axis. Can you see that? And the left gastric artery superiorly.
Yes,
Are you
sir.
seeing it? And you can see the pancreas, the yellowish CZ structure. Can you see that? Okay. Are you seeing it?
Yes, sir. Yes, sir.
Okay. So now see we are moving ahead with the surgery. Okay. So now see the right gastroepiploic vein. Okay, that is being ligated. So to separate the stomach, the right gastroepiploic artery, along with that there will be right gastroepiploic vein, which will go into a trach, which will go directly into the portal vein, so known as a gastrocolic trunk. So it will form a trunk. So the gastrocolic trunk, gastroepiploic vein will drain into the gastrocolic trunk, and then it will finally drain into the portal vein. So you have to separate that gastroepiploic vein to remove the stomach. Are you seeing that?
Yes, sir.
Okay, okay. So now, the common hepatic artery, the CBD, the gastroduodenal artery. Okay, so this is the duodenum here down towards the right medially. The left hand is holding the duodenum, and then the gastroduodenal artery is the branch or the first branch of the common hepatic artery, and you can see the common bile duct here superiorly. Okay, towards the left. Okay, and so all these things, the stations of the lymph nodes are removed, as I have told you in D2 gastrectomy. Let's go back. Okay, so did you see this slide before?
No, sir.
Okay, okay.
No, sir.
So okay, okay. Then see this. D2 gastrectomy is the D2 gastrectomy is the D1 plus 8A9. You can see the last one. Okay. For total gastrectomy, D2 is D1 plus 8A9, 10, 11P, 11G, and 12A. Okay. For D2 distal gastrectomy, only you can see D1 plus 8A, 9, 11P, 12A. So these are the lymph nodal stations which are removed for total. And the see, I will listed the lymph nodal stations here. Okay, 1, 2, 3, 4, 4SA, 4SB, 4D, and then 5, 6, 7, 8A, 8P, 9, 10, 11P, 11D, 12A, 12B and P, 13, 14 V and A, 15, 16. 16 is actually the para-aortic. So all these stations. Okay. So similarly, when you talk about D2, then all these stations for total different lymph nodes are removed, and for the distal gastrectomy, different lymph nodes. So you should say that I'll do a D2 gastrectomy. Okay. So now, so I've shown you about the distal gastrectomy, the Billroth 1 and Billroth 2. I've explained you about that. So Billroth 1, Billroth 2 is the reconstruction technique. It is not the type of surgery you are going to do. It is the reconstruction technique. Okay, so you do a D2 gastrectomy with Billroth 1 or 2 reconstruction. Okay, that is the way it has to be described. Okay, and then the procedure, I told you what are the things. Okay, so then this is I've already showed you this picture. And then see now, everybody is seeing this? Yes?
Yes, sir.
Okay, see now if you see the distal margin, see you can see the tumor there, and the distal margin, we are using a stapler. Okay, that is the intestinal linear stapler. We call it a linear stapler. It has got various sizes. So for duodenum, we'll use a blue stapler. See the color blue is there. So that is the linear stapler. Either you use a 2-row or the 3-row linear stapler to cut the duodenum. See, getting the tumor, you can see the 2-centimeter margin has been taken. See, from the tumor, it is almost 2 centimeter away. We are transecting the duodenum. So the duodenum is being transected 2 centimeter away. Okay. And then stomach is then, once it is transected, it is free from the duodenum and it is lifted up. So you can see the left gastric artery here, the common hepatic artery, and the pancreas. The stomach is being lifted up now. So now, okay, so now you can see the duodenal transected part. Okay, so the duodenal stump. If you see the right below, you can fairly see I've written there duodenal stump. Okay, so the right lower part. So this is the part of the suture, we see that stapler has fired a line there, so which has closed the duodenum. So there is no leak, okay, and you can see nicely the vessels. So the duodenal stump is usually not required to be oversewn, but some surgeons, they don't trust the stapler and they sew the duodenal stump. Then ligation of the left gastric artery. So now once we lift the stomach up, then you have to ligate the left gastric artery, okay? And then see the stomach is being transected now, okay? Transection of the stomach, okay? The stomach is being transected. Now, after you do a subtotal gastrectomy, you will see all the structure clear. Only a small portion of the stomach is being remained. See, we can see everything very clearly. Pancreas, celiac axis, splenic artery, common hepatic artery, gastroduodenal artery, common bile duct you can see, proper hepatic artery you can see, duodenal stump you can see. Okay, can you see this picture clearly? Yes?
Yes, sir.
Okay. Okay. So now, if you see this, see then we are making a anastomosis with the remaining stomach. Okay. The remaining stomach we can see on the right side. That is the remaining part of the stomach, and on the left side where there are the forceps. See, you can see the jejunum being brought up. Okay. Jejunum is being brought up and we are making an anastomosis. See now, if you see this, the completion of Roux-en-Y gastrojejunectomy and jejunal anastomosis. So I can actually, if it was a classroom, I would have made a picture in your whiteboard and told you about the anastomosis, how it is made. But you can see the gastrojejunal anastomosis, how the stomach is being anastomosed with the tubular structure here. That is a part of the jejunum, which is then being down, and then the part which is connecting the duodenum, this part of the jejunum is being again anastomosed with the jejunum. So this is called Roux-en-Y gastrojejunectomy and jejunal anastomosis. And if you see the specimen of the tumor, see how it is seen, and the omentum attached to the tumor, which has been removed, along with the anterior layer of the transverse mesocolon, the pancreatic capsule, okay, and the lymph nodes. So now we'll go into controversies. So everybody is seeing this slide? Yes? Yes, tell
sir.
me. Okay.
Yes, sir.
So can you see the slide? I've written controversies there. Yes?
Yes, sir.
Okay. So now see, so controversy is whether you do a total versus partial gastrectomy. Okay. So it is actually according to the location you'll decide on how much of the stomach you want to remove. Okay. So that depends on the location of the tumor. So we usually prefer to preserve as far as the stomach possible. So we believe on doing subtotal or the partial resection and do a D2 resection at the same time and make an anastomosis. We prefer to make an Roux-en-Y gastrojejunectomy. Okay, so we have to find out now why you need to do an Roux-en-Y gastrojejunectomy in spite of doing a loop gastrojejunectomy. So just find out. So if you want to do why you want to do a Roux-en-Y gastrojejunectomy in spite of doing a Billroth 2 anastomosis. So just find out why it is like that. Okay. So this is okay. Then D1 versus D2 lymphadenectomy. So in this, just remember there is controversies going on, but the standard of care is D2 gastrectomy. So D2 lymphadenectomy is the standard of care. So usually we do in the Asian continent and in the Europe, and also it's very famous in Japan. Okay, so there are various trials which has been done. So that is one of the very popular trial which has been criticized many times is a DOS trial. So in that, so the D2 gastrectomy and D1 gastrectomy, they have compared and they have said that there is no difference, which is not true because of the non-standardized procedure, because people who are learning are also doing the procedure during the study, and then the high mortality rates. So which is maybe related to the high burden of disease. So they have compared D1 versus D2, but they have said that which is not, there is no much difference, but now D2 gastrectomy is the standard of care. So early gastric cancer, I've already told you about the endoscopic mucosal resection for early gastric cancer, okay, done by an endoscopist. And we have already talked about this before. Okay, I'll not go into detail, just find out yourself, okay? Okay, so, okay, so there are a lot of, Japanese people very much interested and they are experienced in doing an endoscopic mucosal resection or endoscopic submucosal dissection. So endoscopic mucosal resection, EMR, and endoscopic submucosal dissection, ESD. So just read about what is EMR and what is ESD yourself. So I don't go into detail because it won't be required for you. Okay, so then learn about robotic surgery. Robotic surgery is the same surgery being done by robot. Robot is nothing but a machine which has been manipulated by an assistant, like a laparoscope. You insert the ports and there will be robotic hands there, and then you can use the various sticks in the surgeon's console, and you can see it in the monitor like playing a video game, and you can nicely do a surgery as you are doing a laparoscopic surgery. Okay, so that is robotic surgery. The procedure is same, only the technology is different. So locally advanced disease, you give or do either a palliative surgery that you do some, if it is bleeding, there are obstruction, you just relieve those things and give an adjuvant chemotherapy and radiotherapy. Okay. So in conclusion, D2 lymphadenectomy is the standard of care, okay, without pancreatosplenectomy. Previously, people used to do splenectomy. Proximal margin 5 centimeter, distal margin 2 centimeter. Reconstruction is Roux-en-Y reconstruction, preferably if the patient is very, very morbid, the patient is in ill health, then you want to reduce the duration of surgery and the morbidity, then you go ahead with Billroth 2 reconstruction, where you can do only one anastomosis. So it will be very, very fast. So doing a gastrectomy and Billroth 2 reconstruction will take you about 2 to 3 hours. But if you want to do an Roux-en-Y reconstruction, then you have to add half an hour to 1 hour more to the surgery. Okay, so are you listening to me now? Yes?
Yes, sir.
So, okay. So the moral of lesson today is do a D2 gastrectomy. Remember the margins. Okay. So remember the margins, how we are going to do the D2 gastrectomy, the margins of the tumor, 2 centimeter distally, 5 centimeter proximally, 5 to 6 actually. And then you remember the D1 means perigastric nodes within 3 centimeter. D2 is along the named vessels. We are going to remove station 7, 8, 9, 10, 11, up to 12. And then do a reconstruction, whether it is Billroth 2 or Roux-en-Y reconstruction. Okay, and then about the adjuvant therapy. And then I'd like to tell you one more thing, that is something about neoadjuvant therapy. Neoadjuvant therapy is now being very, very popular. Neoadjuvant means you give before you undertake any surgery to the patient. So now there is a very famous trial known as magic trial. Okay, if you remember, just go through the net. What is magic trial yourself? Okay, so just find out about magic trial for neoadjuvant chemotherapy. Just go through, just read. If you cannot understand, forget it for now. Okay. Okay. Thank you. Thank you all. Thanks. That's all for today. We finish carcinoma stomach today, and the next class I'll talk you about abdominal tuberculosis. Is it all right?
Sir,
Yes. Yes.
हामीलाई स्लाइड दिन मिल्छ त यो
यो मिल्छ मिल्छ म उसमा लाइब्रेरीमा राखिदिन्छु है I keep it in the library.
लाइब्रेरीमा भन्दा नि इमेल गरिदिन मिल्छ सर
म तिमीलाई लाइब्रेरीमा राखिदिन्छु किनभने त्यहाँ सबैले हेर्न पाउँछ हैन लाइब्रेरीमा I will give it to Sarad and then you can access with him. I'll give you no problem because Wednesday class I'll take it from the from hospital library. So at the time I'll put it there so everyone can access it. Okay.
Yes.
Okay.
Awesome. Thank you.
Okay. Thank you.